What if the pill that's protecting your heart is quietly stealing your energy, your balance, and even your independence without you ever realizing it? What if the dizziness you blame on age, the fatigue you accept as normal, or the brain fog you've learned to live with isn't aging at all? What if it's your medication trying to tell you something important? Margaret Chen, a 71-year-old retired school librarian from Columbus, Ohio, believed she already knew the answer to why she felt so tired every day. For 6 years, she had taken her Lisinopril faithfully every single morning. Her blood pressure readings were excellent. Every appointment ended with the same reassuring words from her doctor. Everything looks great. But Margaret didn't feel great. By noon, she felt lightheaded. By 2 in the afternoon, she was exhausted. Reading, something she had loved her entire life, became a struggle because she couldn't make it through a single chapter without falling asleep. Slowly, she began telling herself the same thing millions of older adults say every day: I guess I'm just getting old. Fortunately, her daughter refused to accept that explanation. She pushed for a second opinion. And when the new doctor reviewed Margaret's records, he didn't change her diagnosis. He changed her medication strategy. What happened next transformed Margaret's quality of life and raised a question every person taking blood pressure medication deserves to ask. I'm Dr. Will, and after years of working with older adults, I've become convinced of something important. Medications like Amlodipine, Losartan, and Lisinopril save lives. That part is not up for debate. They reduce strokes, prevent heart attacks, and protect kidneys. But the conversation around these medications is often incomplete, especially in adults over 65. Side effects that interfere with daily life are frequently dismissed as normal aging when they may actually be medication-related. Today, we're going to explore 6 important things many patients were never told about these medications. And I need you to stay with me because one of these issues is responsible for symptoms that millions of people wrongly blame on aging, while another involves blood pressure numbers that look perfect on paper but may actually increase the risk of hospitalization. Before we begin, I want to give you a framework that changes how you think about every blood pressure medication discussion from this point forward. I call it the dose assumption trap. The first part of this trap begins with something completely reasonable. Your doctor prescribed your medication based on established clinical guidelines. That's exactly what physicians are trained to do. But what many patients never realize is that many of those guidelines were developed using studies involving people in their 50s and 60s, not necessarily people in their late 70s taking several medications while living with bodies that process drugs very differently than they did 20 years earlier. The second part of the trap is even more important. The dose that successfully lowers your blood pressure numbers may quietly be creating symptoms that you attribute to getting older. Fatigue, dizziness, swollen ankles, brain fog, and weakness are not automatic parts of aging. Sometimes they are medication effects hiding in plain sight. The third part is the one that surprises people most. Controlled blood pressure on your medical chart does not automatically mean optimal blood pressure for your body. A number that looks beautiful to everyone in the clinic may actually be making your everyday life worse. That's the dose assumption trap. Your numbers look good, so everyone assumes your treatment is working perfectly, and nobody stops to ask the most important question of all. How do you actually feel? Keep that framework in mind because the first item on our list explains why understanding your medication matters far more than most people realize. 3 medications. 3 completely different mechanisms. And understanding the difference could change everything. 3 medications. 3 completely different mechanisms. And understanding the difference could change everything. Robert Morales was 68 years old, a retired truck driver from San Antonio, Texas. During a routine physical, his blood pressure came back higher than expected. His doctor wrote a prescription for amlodipine, handed it across the desk, and said, "Take 1 tablet every day." Robert asked a simple question that millions of patients ask every year. What exactly does it do? The answer was just as simple. It lowers your blood pressure. Conversation over. For the next 2 years, Robert swallowed that pill every morning without ever understanding why that specific medication had been chosen or how it worked inside his body. He knew the name on the bottle. He knew the dose. But he didn't know the most important part of all. Not all blood pressure medications are the same. Amlodipine belongs to a group called calcium channel blockers. Its job is to relax the muscles surrounding your blood vessels so those vessels widen and allow blood to move with less resistance. Less resistance means lower pressure. Losartan works very differently. It belongs to a class called angiotensin receptor blockers, commonly known as ARBs. Instead of relaxing blood vessels directly, it blocks the effects of a hormone that tells those vessels to tighten and narrow. Lisinopril belongs to yet another class called ACE inhibitors. Rather than blocking the hormone itself, it prevents your body from producing the enzyme needed to create that hormone in the first place. 3 medications, 3 separate pathways, 3 entirely different side effect profiles. And that's exactly why understanding which medication you're taking matters so much. Each class interacts differently with your kidneys, your circulation, your electrolyte levels, and your body's ability to adapt to changes in posture and activity. Those differences become increasingly important as we age because aging changes how our bodies absorb, distribute, process, and eliminate medications. Knowing your medication class isn't a matter of curiosity. It's part of protecting your health. At your next appointment, ask your doctor a simple question. Why was this medication chosen for me instead of one of the others? The answer should be specific to your medical history, your kidney function, your other medications, and your personal risk factors. If the answer feels vague or generic, that conversation deserves to continue. Because once we move into side effects, the differences between these medications become impossible to ignore. Linda Hargrove was 73 years old, a retired postal worker from Richmond, Virginia. She had been taking Amlodipine for 4 years. During most of those 4 years, her ankles were swollen, not mildly swollen, not slightly puffy at the end of a long day. Swollen enough that she stopped wearing the shoes she had worn comfortably for decades. She mentioned it during appointments, more than once. Each time she received the same answer. That's a common side effect. It's harmless. Don't worry about it. So Linda adapted. She bought wider shoes. She elevated her legs every evening. She planned outings around how long she could comfortably stand. Slowly, she accepted that this was simply her new normal. Until one afternoon when the swelling became severe enough that her daughter insisted on taking her to urgent care. What doctors discovered changed the conversation completely. The swelling that had been dismissed for years had been hiding a deeper circulatory issue that had developed without proper monitoring. And Linda's story is far from unusual. Research published in the Journal of the American Heart Association has shown that amlodipine-related swelling affects up to 10% of patients, with rates climbing significantly in older adults and at higher doses. The reason comes down to basic circulation. Amlodipine widens arteries very effectively, but veins don't expand at the same rate. That imbalance allows fluid to move out of tiny blood vessels and into surrounding tissues, particularly around the ankles and lower legs. In younger individuals, the body often compensates for this shift. Older adults don't always have that luxury. Reduced circulation can trigger reduced mobility. Reduced mobility leads to muscle loss and further circulatory decline. And reduced circulation combined with weakness significantly increases the risk of falls. That's not cosmetic. That's not harmless. That's a medical issue deserving attention. If your blood pressure medication is causing swelling, don't accept it's normal as the end of the conversation. Medication adjustments exist. Dose changes exist. Alternative drug classes exist. And sometimes combining smaller doses of different medications works far better than pushing a single medication higher and higher. But amlodipine isn't the only medication with hidden surprises. Because if you're taking lisinopril, what comes next may sound painfully familiar. Because if you're taking lisinopril, what comes next may sound painfully familiar. James Woodfield was 69 years old, a retired electrician from Knoxville, Tennessee. 3 months after starting lisinopril, he noticed something strange. It wasn't dramatic. It wasn't painful. It was simply a small tickle in the back of his throat that refused to disappear. At first, he ignored it. Then the tickle became a cough, a dry cough, persistent, irritating. The kind of cough that follows you into conversations, interrupts your sleep, and slowly takes over your day. James assumed it was allergies. Then he thought it was a lingering cold. Eventually, he began worrying about something much worse. Over the next several months, he visited specialists, underwent chest imaging, and spent countless nights wondering if he was dealing with a serious lung condition. Through all of those appointments, one question was never asked. What medications are you taking? The answer could have saved him months of anxiety. ACE inhibitor cough is one of the best documented medication side effects in modern medicine. Studies estimate that up to 15% of patients taking medications such as Lisinopril experience it, and some research suggests the number may be even higher in certain populations. The mechanism is surprisingly straightforward. Lisinopril blocks an enzyme responsible for breaking down a naturally occurring substance called bradykinin. When bradykinin begins to accumulate, especially in lung tissue, it irritates the airways and triggers a persistent dry cough that cough drops, antibiotics, and allergy medications simply cannot fix. For younger adults, this may be frustrating. For older adults, it can become something much more serious. Repeated coughing episodes increase fatigue. They interrupt sleep. They trigger dizziness and lightheadedness. They increase the risk of falls, particularly during nighttime trips to the bathroom or early morning routines. Most importantly, they quietly reduce quality of life. If you develop a new dry cough after starting an ACE inhibitor, such as Lisinopril, don't assume it's aging, allergies, or bad luck. Talk to your doctor. In many cases, switching to an ARB, such as Losartan, solves the problem almost immediately while still providing excellent blood pressure control. This is not a mysterious complication. It is not rare. And it is certainly not something you should simply learn to live with. At this point, Losartan may be starting to sound like the safer option, but every medication comes with trade-offs. And the hidden issue associated with Losartan and similar medications is one that can become dangerous without causing a single symptom. It begins with a mineral your body absolutely needs to survive: potassium. Unlike swelling or coughing, potassium problems usually don't announce themselves. They don't make your ankles puff up. They don't leave you clearing your throat all day. Most of the time, they remain completely silent. Both ARBs, such as Losartan, and ACE inhibitors, such as Lisinopril, reduce the activity of a hormone called aldosterone. Under normal circumstances, aldosterone tells your kidneys to remove excess potassium from your body. When aldosterone activity decreases, potassium removal slows down. The result is a condition known as hyperkalemia, or high potassium levels in the bloodstream. And here's where aging changes the equation. As we get older, kidney function naturally declines. That doesn't mean disease is present. It simply means the body's filtration systems become less efficient than they once were. Now add a medication that slows potassium removal. Then add foods that are widely promoted as healthy choices: bananas, potatoes, spinach, beans, sweet potatoes, tomatoes. Now add salt substitutes that often contain potassium instead of sodium. Then add over-the-counter supplements that many people take without mentioning them during medical appointments. The result can be a slow, silent accumulation of potassium that continues for months without causing any obvious warning signs. And that's exactly what makes hyperkalemia so dangerous. Because in many cases, the first symptom is not weakness. It's not fatigue. It's not muscle cramps. The first symptom can be an abnormal heart rhythm, sometimes a serious one, sometimes a life-threatening one. Research published in kidney journals continues to show that hospital admissions related to medication-associated hyperkalemia remain alarmingly common among older adults. The solution is simple but incredibly important: monitoring. If you're taking Losartan, Lisinopril, or any medication in these classes, potassium levels and kidney function should be checked regularly. At minimum, every 6 months for many patients, and more often for others depending on kidney health and additional risk factors. At your next appointment, ask one question: when were my potassium and kidney function last tested? If nobody can answer clearly, that's a conversation worth having immediately. But as important as potassium is, there is another issue that worries me even more as a physician. Because sometimes the biggest danger isn't blood pressure that's too high. It's blood pressure that's too low. Because sometimes the biggest danger isn't blood pressure that's too high. It's blood pressure that's too low. Dorothy Flanagan was 76 years old, a retired teacher's aide from Scranton, Pennsylvania. Every time she visited her doctor, she heard the same words: "Your blood pressure looks perfect." Her reading was usually around 118 over 70. The numbers looked excellent on paper. The doctor was happy. Dorothy smiled politely. But there was something nobody was asking. Dorothy was falling. First, it happened in the kitchen. Then it happened in the driveway. One morning, she stood up from bed, took a few steps toward the bathroom, and suddenly the room went dark. Seconds later, her daughter found her lying on the floor. The diagnosis in the emergency department wasn't a stroke. It wasn't a heart attack. It was orthostatic hypotension. Every time Dorothy stood up, Her blood pressure dropped too quickly for her body to compensate. The medication that was protecting her heart was placing her brain, her balance, and her bones at risk. This issue is becoming increasingly important as our understanding of aging improves. Research following the landmark Sprint trial, along with major studies published in internal medicine journals, found that aggressively lowering blood pressure in adults over 75 can sometimes increase the risk of fainting, falls, kidney injury, and electrolyte disturbances. This doesn't mean lower blood pressure is always bad. It means treatment goals should be individualized. The right blood pressure target for a healthy 55-year-old marathon runner may not be the right target for an 80-year-old managing arthritis, diabetes, kidney disease, and balance issues. Let me show you how this cascade happens, because once you see it, you won't forget it. The medication lowers blood pressure. You stand up from your chair. Your blood vessels don't tighten quickly enough. Blood pools in your legs. Your brain receives less oxygen-rich blood for a few seconds. You become dizzy. Your vision narrows. You reach for the counter or the wall. You miss. You fall. The fall leads to a fracture. The fracture leads to surgery. The surgery leads to hospitalization. The hospitalization leads to immobility. Immobility leads to muscle loss. Muscle loss leads to loss of independence. And suddenly a blood pressure number everyone celebrated has changed the entire direction of a person's life. This is why blood pressure management is about much more than numbers on a screen. It is about function. It is about mobility. It is about preserving quality of life. At your next appointment, ask for orthostatic blood pressure measurements. That means checking your blood pressure while sitting and again after standing. Those numbers tell a much more complete story than a single seated reading ever can. Then ask another question that many patients never think to ask. Is my current blood pressure target appropriate for my age and overall health? You may be surprised by the conversation that follows. Because for some older adults, a systolic blood pressure of 140 may actually be safer and more appropriate than 118. The best number isn't always the lowest number. It's the number that protects both your health and your independence. And that brings us to the single most important tool I want you to take away from this entire discussion: the blood pressure medication checkup. 5 questions that every patient taking blood pressure medication should bring to their next appointment. Question number 1. Why was this specific medication chosen for me instead of another class? You deserve an answer that is tailored to your medical history, your kidney function, and your personal risks. Question number 2. What is my blood pressure when standing? Not just when sitting. Half the information can lead to half the picture. Question number 3. When were my potassium levels and kidney function last checked? If you're taking an ACE inhibitor or an ARB and nobody is monitoring these numbers regularly, that gap needs to be addressed. Question number 4. Is my current blood pressure goal still appropriate for my age and health status? Treatment goals should evolve as your body evolves. And question number 5. Are any of my other medications or supplements interacting with this treatment? Pain relievers such as NSAIDs, potassium supplements, certain antidepressants, and even some cold medications can significantly affect blood pressure treatments. A good doctor won't be offended by these questions. A good doctor will appreciate them, because informed patients make better healthcare partners. And now let's return to Margaret Chen, the woman who believed she was simply getting old. Her new doctor didn't perform a miracle. He didn't discover a hidden disease. He lowered her dose and changed her medication class. Within 3 weeks, the dizziness disappeared. The fatigue lifted. For the first time in years, Margaret could spend an afternoon reading without falling asleep in her chair. She looked at her daughter and said something that stayed with her doctor forever. I feel like I got 2 years of my life back. Her blood pressure remained controlled. But now the number on the chart finally matched the life she was actually living. And that's the message I want every person watching this video to remember. Blood pressure medication should help you live better, not simply live longer. If a treatment is controlling a number while quietly stealing your energy, your confidence, your balance, or your ability to enjoy your life, you have every right to ask questions. You have every right to revisit the conversation. And you have every right to advocate for yourself. Because the best blood pressure for you isn't always the lowest one. It's the one that allows you to keep living the life you want to live. If you're currently taking blood pressure medication, tell me in the comments which one you're taking and whether anyone has ever sat down with you and asked if it's still the right fit for you today. Your experience may help someone else watching this video realize they're not alone. And if this information changed the way you think about your treatment, share this video with someone you care about, subscribe to the channel, turn on notifications, and join us for future videos where we break down what medical research actually says in simple language that helps you make better decisions for your health. I'm Dr. Will, and I'll see you in the next video.